Hello, good morning, everyone, and welcome to Semel Grand Rounds. I'm Janice Cho, a recent graduate of the UCLA Psychiatry Residency Program and a new faculty member in the department. It's my great honor to introduce today's speaker, Dr. Srijan Sen, who also happens to be my research mentor. Dr. Sen is the Francis and Kenneth Eisenberg Professor of Depression and Neurosciences and Director of the Eisenberg Family Depression Center at the University of Michigan. He earned both his MD and PhD at Michigan, completed his psychiatry residency at Yale, and returned to Michigan as faculty in 2009. Dr. Sen is also a member of the National Academy of Medicine's Collaborative on Clinician Wellbeing, and his clinical practice focuses on supporting physicians experiencing both depression and anxiety. Today, Dr. Sen will be presenting his groundbreaking work on the Intern Health Study, a longitudinal cohort study that follows physicians in training to examine factors contributing to stress and mood during residency. This study has enrolled more than 28,000 participants across over 100 institutions, producing high-impact findings that span genomics, mobile technology, economics, gender and racial disparities, survey methodology, and medical education policy. Work from the study has been published in leading journals such as JAMA, BMJ, the New England Journal of Medicine, to name a few, and has also been featured by prominent media outlets such as the New York Times, Washington Post, and Time Magazine. I first encountered Dr. Sen's research when I was a surgical intern here at UCLA during a time when I was struggling with depression. I do not hesitate in saying that his work truly saved my life. This past year, I had the privilege of meeting Dr. Sen at APA, and more recently, I joined his lab with the hope of contributing to his transformative research. So without further ado, thank you so much, Dr. Sen, for joining and speaking with us today.
Thanks, Janice. That's really nice to hear, and your story is really inspiring. I appreciate you sharing, and appreciate the really kind introduction, and appreciate all of you guys for having me here to talk. So, as Janice mentioned, I'll be talking about our intern health study and the findings from it related to medical education and other things. I'm going to frame the talk today around trying to make a case for shifting how we think about depression and depression research and practice a little bit to focus more on prevention and going upstream to help make changes that would reduce the number of people who get depressed and anxious, and use the intern health study and some of the work we've done and hopefully some of the progress we've made as examples of how we do that. And in the course of that, get across some of the findings and current state of medical education and physician training. Feel free to interrupt during the talk if you have questions, or we can have discussion at the end. So just sort of starting at a high level about depression. Uh, you all know this, but it's an incredibly prevalent disorder, one of the leading causes of disability. Um, in the US, and affects people across the world, across the age spectrum, and has you know negative consequences to personal lives, families, workplaces, productivity. So really across the spectrum. Um, there hasn't been enough, but there's been a lot of funding in research to try to improve depression and help us fight it better. About $20 billion a year goes into mental health research, and maybe a quarter of that goes to depression or something depression related. The vast majority of those funds have been focused on relatively basic understand neuroscience, trying to understand the brain and how antidepressants work, to develop new antidepressants, to developing these new antidepressants and treatments and clinical trials and other ways of evaluating them, and then promoting the use of treatments and reducing stigma around it. Um, I think there's been this level and this sort of breakdown of investment for about 45 years now, and there's been huge advances that are worth noting and celebrating. we know a lot more about the circuits of the brain and how they interact with each other. This is a visualization of the Drosophila connectome, where colleagues have mapped every single neuron in Drosophila and how they interact with each other, which is an unimaginable feat just 10 years ago. 20 years ago, we didn't know any of the genetic variation underlying depression, and now we know about 700 variants associated and have a much better sense of that. So there's been, incredible advances in our basic understanding. Um, in concert, there's also been real advances in um, reducing stigma and increasing treatment. Uh, Today, compared to 20 years ago, about the proportion of people with depression getting treatment has gone up about 50%. Um, Currently, somewhere around 11% of our adult population are on antidepressants, which is much higher than even 10 years ago. But despite all that progress in our understanding of the brain, in reducing stigma and increasing treatment, we haven't really made a dent in the prevalence or the negative impact of depression. Um, Over the past 20-25 years, the proportion of the population with depression is up about 40-50%, and that's only been increasing even more the last few years. So this calls into question whether our strategy and particularly our funding in how to um, tackle depression is correct, and if there's modifications we can make to it. Um, Certainly, it's helpful to take lessons from other disorders, and while the prevalence and impact of depression has gone up this century, a lot of the other leading causes of death and disability, we've made progress as a field. You're much less likely to get a heart attack and die from a heart attack at any given age. There's been advances in HIV. Cancer is a really um, is a leading cause of death and a really good example. There's been incredible advances in understanding the molecular makeup of tumors and developing new immunotherapies and treatments to help tackle cancer and target our treatments much more effectively. And cancer deaths have gone down about 30% in the last 30 years. But the vast majority of that improvement and the reductions in death are not due to those groundbreaking treatments, but are really due to prevention. Um, 80% of the progress can be attributed to prevention. A lot of it through smoking cessation, better sun protection, things like that. Even though they don't get as much attention as the breakthroughs, they've been the driving factor of improvement in cancer. Um, Unlike cancer, in depression and mental health in general, we haven't invested very much in the prevention area. It only makes up about 7% of the funds we spend on depression, and um, I'd like to argue that increasing that and focusing more on prevention can help us make progress in the same ways that we've seen progress in cancer, heart disease, and other disorders. Um, for the this talk, I've classified sort of ways prevention factors into three categories, and we'll talk about the first two as part of the Intern Health study. Factors that are upstream but specific to individual populations, and then lifestyle factors that affect all of us and could be potentially modified to reduce the number of people who get depressed. Um, so that long preamble brings me to the Intern Health study that Janice talked about, and that I'll spend the bulk of the talk going through. So this is a study uh, uh, you a colleague and I started 20 years ago now, when we were interns or just finished our intern year, um, and we just enrolled and following our 20th cohort, about almost close to 30,000 subjects now. Each year after match day, we invite interns to take part in the study. That period right before internship, usually at the end of the fourth year of med school, is a relatively low stress period, and we do a pretty comprehensive survey assessment of them. Uh, uh, in the last 10 years or so, given them a wearable device or use the one they have, and gotten a DNA sample to try to understand some of the underlying biology. And then after internship starts at the end of June, um, followed them intensively with daily mood scores, and quarterly follow-up surveys. Sort of the heart of the study is this finding that's been we found early in the study that before we measure depressive symptoms through the PHQ-9, and a score of 10 or above has moderate sensitivity and specificity for a clinical diagnosis of depression. Before internship starts, about 4% of incoming interns meet criteria for depression, but by September, about 25% meet criteria, and it stays at that level throughout the year. Depression is episodic, so people cycle in and out. About 45% of interns meet criteria for depression at least once during the year, so a pretty dramatic increase. And it's not just depression; anxiety goes up to a similar degree. About any given time, about 10-12% of interns are suicidal. So it's across a spectrum of psychiatric symptoms. Um, Over the years, we've done a lot of studies uh, trying to identify the factors that drive depression during internship. We measure a lot at baseline, like I mentioned before the year starts, and a series of variables have associate with the risk of getting depressed during the year. Um, there's a story, but behind all of them, and happy to discuss any that of interest. I'll just talk about the gender differences that we've worked on and identified so far. Um, Before internship starts, men and women have pretty similar depressive symptoms, but the depressive symptoms of women go up about 50% more than men through internship and through the early part of residency. Um, there are a number of factors that seem to play a role, from discrimination and gender and sexual harassment. But the biggest single factor seems to be this concept of work-family conflict, with work responsibilities really interfering with family responsibilities, and that causing conflict and depression that goes up for both men and women, but goes up much more for women, and mediates uh, uh, the majority of the relationship, the gender difference in depression during intern year. Sort of the work family conflict continues after intern year as people get out through residency and then out into early practice. Um, uh, and it but it lessens through that time, but not because medicine has found a way to manage the work family conflict in a um, sort of thoughtful and um, forward-looking way. It's mostly managed by women working less and dropping out of the workforce. Within 6 years of finishing residency, only about 60% of women are working full time, where in contrast, almost 100% of men are working full time. And of the women not working full time, about half have dropped out of medicine, and half are working 2 days a week or less. So this is a real problem both for individual physicians who have done incredible work to get to that stage and are unable to work, but also for the field of medicine, where we have a huge and growing shortage of doctors, and addressing this disparity is a critical thing we need to do going forward. Um, One of the other major disparities in medicine, uh, uh, gender disparities, is in pay. Even women make up the majority of incoming medical students and residents now. but across the board get paid substantially less than men. Part of that is the specialties that are predominantly male and female. And this is a study done by uh, uh, Dr. Pereira Lima in our lab, and found that there's been real progress in the number of women in one subset of the sort of high paying specialties, the surgical high paying specialties, where the proportion of women has gone up about from below 30% to above 40% um, in the last 15 years. But that progress hasn't been made in the non-surgical specialties. And so figuring out why there's been progress in those high-paying surgical specialties, and sort of implementing those changes more broadly is also an important thing to do to help address the gender disparity. In addition to sort of those baseline factors, we've identified a lot of factors about programs and factors during internship that associate with greater risk of depression. Um, and these are sort of potential factors to target to improve depression. Um, One of the problems I think in the field of medical education and in sort of human research in general is jumping too quickly from associations and correlations to assuming a causal relationship, and oftentimes we um, target things that aren't really causal and waste time and resources and slow progress. Associations and correlations can be due to real causal relationships, but they can also be driven by these confounds, reverse causation, and other things that can lead us down the wrong path. Um, Traditionally, the way to really move from correlation to causation is clinical trials, and we certainly require that for assessing new drug treatments and other interventions. But for a lot of the things that we're interested in here, doing a real clinical trial is not feasible. We can't um, uh, sort of reliably assign interns to sometimes sleep 4 hours a day and sometimes sleep 8 hours, or um, uh, or to exercise or not exercise in a way that would be reliably followed. So an approach that's been developed in the last decade and really flourished is this concept of target trial emulations, where you use observational data that's set up a certain way, and specifically data like ours in the intern study, where there's a clear start of intern year, clear time zero, and then arrange the data and do the analysis in such a way that you're emulating a clinical trial. So um, figuring out what the clinical trial question would be, and then setting up the observational data to exactly sort of answer that question. So we've done that with a few of these different variables, and broadly in the field, when folks have used this target trial approach, the results seem in line with traditional randomized control trials. So we did that for a few different variables, and most importantly, we did it for work hours. And when we assigned people to different emulated the trial of assigning people to different work hour levels, um, we see a clear, strong and linear relationship between work hours and depression. So folks working, you know, 80 plus hours a week have about 2.5 times the increase in depression compared to people working, 50 hours a week. Um, and we can see, I think, more than I expected, that the effect doesn't sort of reach an asymptote at some time, but even going down to lower work hours like 45, 40, and even 20 to 40 work hours, we still see the linear relationship between work hours and depression. So this implies that targeting work hours and reducing work hours would reduce depression among interns and physicians in general, and that's broadly what we find. Since we started the study in 2007 up until 2019, and the trend has continued in even more recent years. Uh, right now, an intern starting has about 25% less increase in depression and less chance of getting depressed than an intern starting in 2007. And a few different factors seem to play a role. Interns are sleeping a little bit more. A much, much higher proportion of interns who are depressed are getting treatment. But far and away, the biggest driving factor in this is work hours. Interns are working about 7 hours less a week than interns 20 years ago, and that seems to be the major driver of the improved mental health. So the depression rates are still way too high among interns and much much higher than the general population. Um, so there's still work to go to reduce it, but there's been some progress. Um, we also get sort of some more confirmation that work hours are an important factor through a couple other natural experiments. I'll go through the COVID one here. At the start of the pandemic in the US, in March of 2020, there was, as you all remember, a dramatic change in society, and one of them was that hospitals um, were overwhelmed in treating COVID patients. But because of that shutdown, a lot of non-essential services and because of that, work hours among interns went down. Still, even at its lowest point, was still higher than the normal person's work hours. Interns were still working about 48 hours a week, but it was much lower than the 60 hour week baseline. And then sort of the work hours came back to normal, and by June we're back to pre-COVID levels. But you can see that the levels of depression followed that pattern as well. Like even in April of 2020, which in the general population, depression rates were skyrocketing with sort of concerns about COVID, was actually the lowest level of depression we've ever seen in the 20 years of the study. But then as work hours went back up, the depression rates went back up to population to previous COVID levels. And the work hours seem to mediate again the majority of the decrease in depression that we saw during the early stage of the pandemic. Um, so all this is to say that work hours are clearly the most important driver uh, of of depression and poor well-being among interns and among physicians in general. And like I alluded to a little bit earlier, that there's still a whole bunch of room to reduce work hours in all physician populations, but particularly interns, and that more work to offload administrative tasks and other non-educational work to bring work hours down even below the 61 level it is now, and particularly in surgical specialties, um, would likely have really big effects on improving mental health. Um, I take a little tangent now. I've talked only about depression um, and mental health so far, and there's been probably the majority of work certainly in the field and in common conversations about well-being among physicians has been more about burnout, and so I just wanted to mention why that is and why I've been talking about depression. I think uh, the conversation about burnout in the last decade or so has been really good for medicine in the sense that it's allowed us to talk about well-being and the stresses of medicine much more than what was sort of part of the culture 10, 20 years ago, and allowed people to express what they're going through. Um, I think there's also some downsides to how burnout has evolved, and I think to some extent it's a barrier to progress. So particularly among psychiatrists like us, I think trying to shift the conversation to depression could be a way to make more progress. People have been talking about burnout as due to the system, um, and contrasting it to depression, anxiety, and suicide in ways that implies that those things are not, depression is not due to the system, but due to flaws in the individual. And I just had a couple of quotes from folks where they do that, I think unintentionally stigmatizing depression, but that comes through. And I think that's a real problem. I think burnout itself is a sort of flawed construct in a few ways. Um, One is that it doesn't have a clear definition. Again, both colloquially how we talk about it, but even in the literature, we try to do a meta-analysis of burnout levels among physicians and weren't able to do so because in the 180 so studies that were out there, there was 142 different definitions of burnout, um, and with those different definitions, the prevalence ranged across, almost from zero to almost 100%. So it's impossible to really make progress when we're all talking about different things and studying different things. Um, the other sort of major problem that I've found with burnout is that it doesn't have face validity. So burnout was created and um, uh, postulated to specifically capture stress and symptoms that result from the workplace. But as we showed in this study, and there's a dozen other studies showing similar things, that burnout doesn't really do that. That it's as affected by individual factors like um, uh, marriage difficulties or other stresses at home or personality and difficult childhoods, just to the same extent that depression and anxiety are, and almost the same factors that affect depression affect burnout, at least when measured by the sort of gold standard Maslach scale. So it's really not capturing what it is purported to capture. Um, so all that being said, I think we can take advantage of the progress made with burnout, but really, if we bring depression more into the conversation, it can um, help research move forward in a more rigorous way. We can help reduce the stigma around depression and mental health, which I think is important. And then also we have a lot of the interventions we have for depression are not perfect, but we know things that I'll talk more about in preventing depression and treating depression, and all that can be brought into sort of our armamentarium for physician well-being if we expand the conversation from burnout to depression. Um, so thank you for tolerating my little diatribe, and happy to talk more about it. But there's a couple of articles that I and my colleague Connie Gill go into greater depth about the how to move forward with well-being in physicians and steps we can take both as researchers and healthcare organizations to make progress. So I'll stop talking about physicians specifically now and shift over to how we use the intern model to help understand depression and prevention of depression more broadly. One of the relatively unique features of this model of looking at interns is that it's a rare situation where we know people are relatively well adjusted and have low levels of depression and stress in May, and then reliably, half of them are going to end up getting depressed at some point during the course of the year, and because of that, we can follow things prospectively um, and really focus on prevention and try different things to see what factors are really driving that increase in depression in each individual and try interventions to stop it. So I use the work hours as sort of an exemplar of the population specific factors in physicians. I'll shift now to the lifestyle factors. There especially in recent years been more focus of lifestyle psychiatry and these sort of focus on activity and sleep and social connection, uh, and the roles that they play um, in increasing depression and driving that, from a more fundamental perspective. These are also a lot of the factors that, we see change with the start of internship, and that, associate strongly with depression. Um, and so this seemed like a natural place to study it and try to understand it better. Um, One of the problems in lifestyle psychiatry, and really more broadly in making sort of progress in improving things like, exercise and sleep and, social connection, is that traditionally we've studied that all by self-report, by asking people how much they're exercising or, sleeping. And the nature of that is that the data isn't very good, that it's, inaccurate and subject to biases, and we only get it sort of intermittently when people, come into the office and tell us about it. Mobile technology is, allowed us in the field to study some of these things much more, quantitatively and in real time and passively. And so we've tried to take advantage of that to help, make lifestyle psychiatry and the assessment and interventions of those factors much more, tractable. All of the interns in our study, have a wearable device and answer, or asked about their mood every day, and we try to use that relationship to move things forward. Um, Over the years, we've, found a bunch of mobile technology factors that, within individuals correlate with worse mood, and then across people, associate with less depression, and listed, some of the more important ones here, and happy to talk about any that are of interest. Just to give a couple of examples, I think we all know and have long known that, like, sleep duration is important, and particularly among high, people are working a lot, like physicians, um, uh, not sleeping enough is a chronic and big problem, and improving sleep duration is important. One thing we're able to do with mobile technology is to get other sleep constructs, and we find that the variation around sleep, seems to be as, and in some cases, more important um, than the absolute amount. So, um, the right side of these graphs is this the variation or standard deviation of sleep variables, and the first one, you can see that variation in total sleep time is important, and in some ways even more important than the sleep time. So sleeping, um, if you're sleeping, let's say 7 hours a night, sleeping 5 hours some nights and 9 hours some other nights is correlates and seems to drive, worse depression much more than sleeping 7 hours every night. And sort of similarly with the timing of sleep, it seems really important to have the sleep period happen at the same time every day, and going to bed at the same time, or not having that much variation is much more important than what your actual bedtime is. Um, so targeting this variability is important, and also something we couldn't do without the quantitative measures of mobile technology. Related to that last point, we find, another, like, big driver of depression and poor mood is circadian misalignment. We can, through the Apple Watches and Fitbits, get at a variable of circadian misalignment. Essentially, um, uh, in ideal circumstances, the midpoint of your sleep. So if you go to sleep at, um, you know 11 p.m. and wake up at 7, the midpoint would be, 3 a.m. Um, Ideally, the midpoint of your sleep correlates with your internal circadian clock and corresponds with sort of the lowest heart rate you have, over the course of the night. And the amount that those are misaligned, we find, associates with mood. So days when that's more misaligned, your mood is worse. And then people who have more misalignment in that have more depression. And the magnitude of this is relatively big. And again, this seems like a good target for interventions to prevent depression and targeting sleep specifically here. As I talked about before with work hours and some of the internship specific factors, there's risk of a lot of these factors too being correlations, but not really being causative. And it's important before creating interventions and really making changes that we know which ones are causal and which ones how strong that causal effect is. So we did target trial emulations for these factors as well, because again, it's important. It's nearly impossible to do real clinical trials with them. Um, Another important factor that we wanted to incorporate and I think are important to move the field forward is getting more personalized and precise in these effects. You know, all of those lifestyle factors that we talked about, getting 8 hours of sleep, sleeping at the same time every day, eating nutritiously, having good social connection, exercising and other things. It's really, practically impossible for anyone to do all those things reliably well. And we often feel like we're failing if we don't do that. Probably what's important for different people, what's really important for my well-being could be really different than what's important for Janice's well-being and for all of us on this call, and trying to identify which is the most important factors of those lifestyle factors for each of us. It can help make it more practical to target and to focus on. So one of the potential drivers of the differences between what's important and for each individual is genomics. About 40% of the risk for depression seems to be related to is heritable and through genes, but there isn't any one gene that's really important to depression. It's spread out across thousands of variants across the genome. So a tool that's been helpful in cases like depression where the genetic risk is spread broadly across the genome are these things called polygenic risk scores, where we can sum the tiny effects of each variant and sum across 10 million variants and come up with one single score. These uh, polygenic risk scores are based on huge consortia studies, so that there's 23andMe and the Psychiatric Genomics Consortium has looked at over a million people comparing depression and non-depressed and developed these polygenic risk scores. We can apply that from those huge consortia to the intern sample, and you can see here sort of the lower line shows the relationship between this polygenic risk score and depression at baseline. So this is in April, May, before the start of internship. And that line, there is a little bit of slope. The people with high polygenic risk scores on the right side of the graph have a little bit higher rate of depression than people on the left side of the graph, but it's a pretty small effect. But the influence of the polygenic risk scores grows substantially under stress. So during internship, you can see people with high polygenic risk scores are substantially more depressed than people with average polygenic risk scores, and then those average people are really a lot more depressed than people with very low polygenic risk scores. So just showing how the global risk for depression manifests and how it seems greater under stress and internship stress. Um, so we incorporated both those sort of emulated trials, the mobile technology to gather more concrete and quantifiable constructs, and then these genomics to try to put it all together to try to identify which of these proximal lifestyle factors are important in depression and which are important for different individuals. Um, so here's one example with social support. And the darker blue line are people with a high polygenic risk score for depression. The lighter line is people with a low polygenic risk score for depression. So you can see sort of on the left side of the graph is the situation you'd expect. People with high polygenic risk for depression have much higher depression rates under the conditions of having low social support and losing a lot of social support. But as you go across the graph to people who were have good social support and are actually gaining social support, you see the lines cross. So under conditions of good social support, people who have a high polygenic risk for depression actually have lower depression than people with a low polygenic risk. So what is sort of put forward as a polygenic risk for depression seems in this context to be much more of a sensitivity to the social environment, and people with the higher genetic load are actually thrive more in really good social conditions. With the emulated trial framework, we applied this to many of the other lifestyle factors. This is exercise and step count, and you can see assigning people to different levels of steps, below emulating a trial as if we were doing that, assigning people to less than 6,000 steps up to, greater than 10,700 steps. You can see people with higher steps have lower depression and lower increase of depression with internship. Um, and so there seems like a significant relationship between step count and depression. The overall effect size of this is about half as much as is commonly found in observational studies and meta-analyses of that. So it seems like half of the relationship between step count and depression is real and causative, and the other half is probably due to confounding and people who take a lot of steps being different than people who don't take a lot of steps. But the sort of emulated trials can help tease that apart. And then we applied the polygenic risk score for depression to this, and we find that the effect of exercise and activity on depression is substantially greater in the people with a high polygenic risk score. So they have a much bigger effect of exercise in reducing their depression. People with a low polygenic risk score either don't have much of a response to depression, don't seem to be that sensitive to exercise, or if it is, it's only at the really high end of the step count range. Um, Similarly, with total sleep time, we see an overall effect of the more sleep you get, the lower the depression. But that effect again is much higher among people with a high polygenic risk for depression than people with a low polygenic risk score. Um, so I don't want to run through every single variable, but when we do, for most of the factors, the high polygenic risk group seems more sensitive to sort of sleep time variability. It's actually the opposite, that the low polygenic risk score are more sensitive to that factor. It's certainly early days with this stuff, and there's a lot more genetic factors to look at than just this depression polygenic risk score. But hopefully, it gives you a sense of how we might be able to identify who's most sensitive to which factor, and then target that in that individual. So I'll stop there. I ran through a lot of stuff and a lot of papers, but hopefully it gave you a flavor of the work and hopefully gave you some food for thought on how targeting upstream modifiable factors, either the sort of population specific factors like work hours or more of these global lifestyle factors has potential to really reducing depression and helping us make progress. And hopefully you got a sense of where we are with depression among training physicians and where we've made progress, where we need to do more. And then a little bit about these different tools we've been using to help identify the most important factors and target them in a more concrete and quantifiable way. So thank you for listening, and all this work is done by my amazing team, with Janice is now a part of, and I'm really appreciative of them and appreciative of you guys of listening, and would love to answer any questions and have discussions. Thank you.
Thanks so much, Dr. Sen. This is such an inspiring talk, one that I have heard a few times now, and I think I learn something new each time. And it's so
Thank you.
important and I think needed for a community. Um, so I'll start us off, and I'll also have folks kind of post on the Q&A chat as we go through the Q&A session if you guys have any questions. But I'm interested to know, how did you get into this type of work that traditionally I think has so much stigma associated with it?
Um, yeah, thanks for asking, Janice. I think uh I mean I have depression myself and both earlier in life and then got pretty depressed during for me it was more in medical school and struggled with that, and I have my mother struggles with depression, but probably this one of my best friends in medical school then went on to residency and died by suicide during his psychiatry residency, and that was I still think about that a lot and things why that happened, what I could have done differently, and so I think that um, drove sort of my, we have different coping mechanisms. Mine is to do research. So I think that was part of the inspiration for starting the study and through the work hear about that similar sorts of stories from a lot of people and a lot of institutions and hope that some of the work we do can make that less common and less physicians struggle and ultimately die by suicide is one of my major goals.
Thank you so much for doing this work. I know when I was struggling, I really wanted to kind of find answers or feel like there was a community or that other people felt this way. And I think, you know, anxiously going through PubMed to kind of make sense of what I was experiencing, I found your work and it was just so impactful. So I really appreciate all
Thank
the effort that you continually put
That's
into this.
that's
Um,
really amazing to hear and makes it feel all worthwhile. So thank you. Thank you
yeah.
for sharing.
And in terms of some of the questions that we have from our listeners, so one asked if when you're kind of surveying the interns, if you ask about religious affinity and practice.
Great question. Yes, and I we just published a study on that. And we ask about religious, how much, whether people are religious and how much time or how often they attend religious services or engage. And um, at baseline, that seems to be a strong predictor of depression. So people who are more religious and attend religious practices more going into intern year get less depressed during the year. Uh, and those who continue during intern year also get less depressed. So it seems like a um, sort of what we could call like a resilience factor for depression. I think we didn't look closely, but we didn't find any major differences between different religions or what the specific affiliation was. But the um, I think it'd been previously known that religious, just cross-sectionally, religious people were less depressed than non-religious people. I think we're finding that it's perspective that it predicts in the future less depression. So I think what to do with that information is up for discussion and debate, but it was a more robust association than I had anticipated before we did the study.
Interesting. Another listener asked kind of what role do you feel insecurity and competency as a young physician adds to the depression component of internship?
Yeah, I mean, I think a lot. it's a really difficult time, and especially people get that far, like get through medical school and into medical school, and by being really uh, yeah, proficient and thriving and doing really well, and then getting thrown into a situation where really it's all new and you don't know what you don't feel competent and feel like an imposter is difficult and can feed into depression. In some ways, the rotation system is sort of set up to be, once you start feeling, like what you're doing and how things work in a certain unit or a certain rotation, you're, taken out of that and put into a new place. So it definitely contributes. And then once people get depressed or start feeling depressive symptoms or anxiety symptoms, it can feedback more negatively to the thoughts of incompetency and or not being as knowledgeable as others. So I think it's a big part of it. And being, I think, aware of it, for people going through it, and aware that most of their colleagues are feeling the same way, um, is important to know to help get through those feelings. But yeah, I think it's a really big part of it and a good question.
Yeah, definitely. Especially because I think imposter syndrome, especially being, first generation, like not having parents in medicine, I think already coming in, I felt definitely vulnerable to, being a new doctor. So yeah, that's an interesting point that you make.
Yeah,
Um,
and I think a lot of it, like, I think we're changing hopefully a little bit, but we're still trained to like put on a brave face and act like we know what we're doing, and so I think unless we explicitly talk about it, at least in my patients I see who are physicians, often feel like they're the only ones going through it, and but then once you start talking about it, you realize everyone kind of feels like an imposter, and that they shouldn't be there, or many or most do, and that, I think, having those conversations can help.
yeah. There's a comment that one of our listeners had made, and then I do actually have a question kind of going off of that, which is that more than 20 years ago, when working and treating medical students and residents, our clinic director used to say, I wish we could screen everyone coming in, and those who score high on measures of stress, depression, etc., should be put in one line and given treatment from the outset of their studies. So kind of going off of that, based on what you see in residents, as well as the studies that you've done with medical students, kind of are there particular moments or transitions in training where prevention efforts should be concentrated, and how do you recommend kind of doing that in an ethical way? Because I think as a neurotic medical student myself, I feel like I probably would have kind of tuned this out in medical school, and then
Mhm.
lo and behold, struggled.
Yeah, I think I mean, I think the transition periods are really risk periods. So um in what in our case, that the transition from medical school to internship is really hard, and a period to focus. And I think, and the period before that, really um an area to we did one intervention with Mood Gym, which is a online CBT program, and when people went through 4 or 5 hours of training on that, in May and June, they got much less depressed during internship than people who didn't go through that training. So I think the um, focusing on the period right before internship, or any sort of difficult transition, um, it makes sense. I think the um, screening, there's definitely value in that, and different programs have different success with it. I think one risk is if it's driven by the program, then there is still a lot of stigma, and some people are not going to be honest, and may be depressed or may have risk for depression, but don't want their program director and leadership to know that. And so we got to fight the stigma, but also providing people ways of getting help that they could do so, confidentially and so outside the system. Again, there's a lot of online tools now that are effective and people can access. So I think I'm giving a meandering answer, but I think that he is allowing interns and encouraging all of us to figure out what's important for ourselves. So figuring out in the period before things get really bad, whether sleep or exercise or, hanging out with friends a couple times a week or whatever the most important things are for you, and prioritizing that, and then getting help and a help network set up beforehand. So if therapy is going to be important, then starting that before. I mentioned the Mood Gym is the one we've used, but doing that in a way before things start, and then having access to different things and whatever will help are important. So, but yeah, broadly, I agree with the premise of the question, and I think we're doing better as a field in this, but we could do even better if we make progress in the next few years.
And kind of on the topic of work hours, I mean, I think your studies show that work hours directly correlate to depression risk, so like a linear correlation, and kind of wondering what are practical steps that residency programs can take to reduce work hours, but also kind of balancing patient care needs as well as, you know, being a good clinician and having enough kind of clinical experience to kind of be proficient once we graduate.
Yeah, it's a good question, and I think there's no magic answers. Um, I still think there's a lot of I don't know, meat on the bone of like non. Um, there's definitely work and like clinical practice and time with patients that we all need to become um, better physicians, and that's important. There's a lot of other work that particularly residents do that isn't that's maybe you need to figure out how to call radiology once and twice to figure out what that's like, but like the hundredth time of arranging prior authorizations or transporting a patient somewhere or filling out that same note is not educational anymore. So I think there's a lot of administrative work that we can still that's crucial and important for the health system to run to function, but it isn't educational for the residents. And so the residency programs, institutions that have done the best in reducing depression by reducing workload have really reduced that administrative burden, either by bringing in more residents or physicians or clerks or physician extenders, and I think now how we incorporate generative AI into this is part of it. But really, I think targeting the administrative burden and making sure that every hour that the residents are there is really educational and helping them become better doctors.
All right, thank you. And the last question we'll take from the audience is that, given the focus on individual medicine, like even if you find certain groups, higher polygenic risk scores, et cetera, have a higher risk factor for depression, would you still offer all aspects of kind of treatment or interventions that can prevent depression? And would you
Mhm.
counsel in medical school or just before internship to use these preventative factors?
For the latter, I think, yeah, as early as possible, and whenever yeah, I think even yeah, in medical school and as undergrads, I think, and I think yeah, definitely, um, offering everything to everyone is great, and what we should do, but I think also being cognizant that it's hard for anyone to do everything in the preventative realm. And so if we can provide, I don't think we're there yet, but if we can provide the um, guidance and information, and there's some other stuff that I didn't talk about with wearables, but some people are really sensitive to, circadian misalignment, and letting them know that can help them prioritize uh, that in small ways. And in I'm one of those people, and like I really liked aspects of surgery and anesthesiology, but I can't, I wouldn't be able to function as a adult, sort of waking up at 5:30 a.m. every day. Um, uh, so for other things, letting people know what they're sensitive to, and prioritizing that as a both for doctors, but also the general population. I hope we can move more to.
Thank you so much. Well, we're a minute past 12, so in respect of your time and everyone else's time, thank you so much for being here and for everyone for attending. Thank you.
Thanks. Bye.
Bye.